Good evening, everyone. Welcome to the Indian Fertility Society in association with IFS SIG Endoscopy and South Tamil Nadu chapter program with the theme of Just Fibroids. So today I welcome Dr. Pankaj Talwar sir and Dr. Shweta Mittal Gupta madam, President and Secretary General IFS. Sir is not available. Shweta madam is there.
I will keep moving whenever they join.
Yeah. And I introduce, can I see the screen?
Yeah, and I'll just share the screen. Keep moving the CVs. Rahul?
Yeah, the next CV.
Next.
And the next one. Yeah, so I introduce Dr. Ashok Khurana. He's a mentor of SIG Ultrasound. He's chairman and consultant of reproductive ultrasound in the Ultrasound Lab, New Delhi. He's a professor, School of Health Sciences at the Durban International University, Croatia, professor, Intermedical Association, past president of the Society of Fetal Medicine, former ISUOG ambassador for India, former dean, Indian College of Medical Ultrasound. We welcome you, sir. Then I'd like to introduce convener SIG Endoscopy, Dr. Parul Kotadwala. He's endoscopy surgeon and consultant gynecologist, professor, head of department, Sal Institute of Medical Sciences, Ahmedabad. Kotawala Women's Clinic. He's senior consultant at Zydus Hospital, Ahmedabad. Chairman, ICOG, Vice President, ISOPAB. Chairman, Education Committee, SAFOG. India Coordinator, and NISA and IS. He was the Vice President, FOXY, and President, SOGOG. So many laurels. Next, we have convener SIG. Next, we have patron South Tamil Nadu, Dr. Ramni Devi. She has been a president TNFOC for 2024. She's now vice chair elect of ICOG election for 2024, vice president FOXY 2020, was a chairperson endometriosis committee of FOXY, and was a governing council member ICOG 2018 to 20. She has many publications, award, research work, and teaching experience, many conferences organized. She's on the editorial board of she's the national corresponding editor of Jogi and journal ESI. And she has many public programs and so many social awards. We welcome you, ma'am. Next, we have our convener SIG Ultrasound, Dr. Bharti Jain. She's the director, KGIVF and Laparoscopy Center, Delhi and Faridabad. She's a consultant sonologist with more than 20 years of experience, ART consultant, former senior specialist at ESIH, Delhi. She's an excellent academician and orator who has written many chapters in book, and she's heading the charity wing of KGIVF, Dhanvantri Trust. We welcome you, ma'am.
Thank you. Then Madam is there. Madam will have a blessings and Madam will open the session today.
Yes, Bharti ma'am, we'd like to have your blessings, ma'am, please.
Good evening, all. As a convener SIG Ultrasound, it is my proud privilege today to welcome Dr. Pankaj, President IFS, Dr. Shweta, Joint Secretary IFS, all the faculty and the delegates for this CME. And I thank you all for having spared your valuable time to be a part of this CME. Today's CME is important as it is a joint venture of two special interest groups, ultrasound and endoscopy. And the aim is to exchange views and to learn the tips and tricks of imaging and to keep abreast of the latest management guidelines. The topic today, fibroid, is very important. The scanning is easy. There are not tricks in diagnosing fibroid, but the real challenge is to map the fibroid, especially when we have large and multiple fibroids. And because we know the management varies with the location, especially in infertility patients. And the next challenge in infertility patient is the priority of infertility management precedes over the fibroid management. So today, I'm sure all of you will enjoy in this CME today, where both the clinicians and the imaging people are together, and we have a beautiful panel. So now I open the conference, and now the mic is with the master of ceremony today. Thank you.
Thank you, ma'am, for your encouraging words. So we look forward to this wonderful CME. Next, we move on to our co-conveners of SIG Ultrasound, Dr. Ritu Khanna. She's Director of Khanna Medical Center Clinic and Fertility Specialty and Endoscopic Surgeon. She's been National Vice President, India Fertility Society. Is co-convener SIG Ultrasound, Chairperson, Foxy Food, Drug, Medico, Surgical Equipment Committee, Secretary Society.
Move forward.
Yeah.
Short, yeah.
Yes, ma'am. And then we have Dr. Labdans Kaur, and she's the Director and Consultant Radiologist and Fetal Medicine Specialist, Prime Diagnostic Center, Chandigarh. She's pioneered in TVS sonography, peripheral color Doppler first trimester ultrasound, 3D, 4D obstetric and gynecology ultrasound, and she's vast experience in fetal diagnostics, high-risk pregnancies, fetal interventions, so many talks and deliberations, and many scientific associations and awards. We welcome you, ma'am. And we move on to Dr. Chitra, ma'am. She is the Secretary of South Tamil Nadu chapter. We welcome you, ma'am, and seek your blessings.
Dr. Chitra is there.
Chitra, ma'am.
Dr. Chitra?
Yes, thank you very much, Priyanka. And I'm very happy to be here on this eve where we have a meeting with the SIG group of two important fields which we all always work with. Either endoscopy or ultrasound is a part of gynec workup for all of us. And I'm very happy I could be very comfortable with the Dr. Ritu in organizing this. And I hope all of you all enjoy this meeting. South Tamil Nadu chapter is a new chapter in IFS. So I want more, people to be involved in this, and we do more and more meetings like this. Thank you very much.
Thank you so much, ma'am. So we move on to the session, the first session. Next slide, please. So session 1, we have our chairperson, Dr. Radha. She's Director and Infertility Consultant of Prasanna IVF Center, Sriveliputtur, UG from Tirunelveli Medical College and PG from Kilpark Medical College, and she's Secretary of Virudhunagar West Society. And Dr. Chandra Punnusamy, madam. Next slide, please. Next slide, please. Yeah. She first started the laparoscopic and IVF center in her district, Namakkal. She delivered the first IVF baby and ICSI of her district. She has been Foxy member since 1982, life member of so many societies, founder president of Namakkal Women's Doctor Association, founder president of Namakkal OG Society. She has so many awards and she's been faculty in many international national conferences. Welcome you, ma'am.
Yeah,
Next slide, please. Dr. Rashmi Ajit, Associate Professor, Kanyakumari Medical College, past Treasurer, NOGS, and past Secretary, NOGS. We welcome you, ma'am. Next slide, please. So, Dr. Uma Velmurugan, ma'am. She is the Managing Director and Chief Consultant of Venus Fertility Center, Trichy. She is a consultant OBGYN at Apollo Specialty Hospital, Trichy, Secretary Trials at present, Executive Committee Member, TNFOG, Founder, President of Trichy Chapter, Tapisa, Organizing Chairperson, Rockford, Young Talent Award, ISA. We welcome you, ma'am. So, moving on to the session, I request the chairpersons. I request Dr. Radha to introduce Labdans Kaur, ma'am.
Hello. Thanks for the invite, to ma'am. I'm happy to introduce Dr. Lord Scott, ma'am. She's the director and consultant radiologist and fetal medicine specialist, Prime Diagnostic Center, Chandigarh. And she has pursued MD radio diagnosis from PGI Chandigarh, and she has pioneered in transvaginal sonography, peripheral color Doppler, first trimester ultrasound, 3D, 4D obstetric and gynecology ultrasound. And she has vast experience in fetal diagnosis, high-risk pregnancy, and fetal interventions. She has delivered more than 200 talks and deliberations on obstetrics and gynecology at various national, international, and regional conferences. He has key faculty positions in approved advanced course on endometriosis 2021 and approved course on one-step series fetal trimester and approved global conference on gynecology ultrasound. She has best paper award for oral presentation on ISUOG 2012 and more than 68 publications in peer-reviewed and indexed medical journals. And she has scientific associations with International Society of Ultrasound in Obstetrics and Gynecology, Fetal Medicine Foundation UK, Society of Fetal Medicine India, Indian Radiological and Imaging Association. We welcome you, ma'am.
Thank you. Thank you so much for a very kind introduction, Dr. Radha. And thank you for having me again for this platform. And I'll be speaking on today. I'll just share my screen. So, here we are. I think you can see the... Yes. Yes. So here we go. So today I'll be talking upon the decision and precision. You know, when we talk about fibroids, we really need to make sure that are we looking at actually a fibroid? So sometimes, you know, we always say it's very easy to diagnose a fibroid, but it's not that easy at times, right? Sometimes it becomes very challenging. And so today is talk where first off, we'll talk about how easy it is. And I will tell you, I will take you through a list of very challenging situations where things look very, sinister, but yet you need to know when there are markers where on ultrasound, which gives you a clue that I may be looking at something which is not benign. So all that thing is important because whenever you're imaging, you may not be, I'm no doubt an infertility patient. Yes, we know what to do with fibroids, but there are certain situations which a woman comes with and has malignant pointers. So how to go about that process? So I'll take you through a journey of diagnosing and mapping up of the fibroids. So we all know that these are benign tumors of the myometrium composed of smooth muscles and connective tissue and is seen as commonly as 40% and is seen by the age of 40 years. So if I may not be wrong, that if we are all in the webinar today, maybe 5 of us must be holding few of the fibroids too. So this is basically the fibroids happen because of the transformation of the normal myocytes to abnormal myocytes. And they do have a common phenotype, but they may have underlying genotypes. So some somatic and inherited mutations also account for these leiomyomas. As far as the risk factors are, their contributory risk factors include parity, include increased exposure to the hormones. The more parous woman, the more high exposure of hormones, there are more chances of having fibroids, early menarche, than people who are on hormonal contraception. And endocrine factors do include prenatal exposure to ethyl stilbestrol, obesity, diet, alcohol, and smoking. As far as the symptoms go, they may be asymptomatic in 2/3 of the women, whereas they present with heavy or prolonged menstrual bleeding and in the form of menorrhagia, polymenorrhagia, metrorrhagia, and also they can present with a large pelvic mass. And because of the large pelvic mass, they could have bulk-related symptoms as pelvic pressure and pelvic pain. They may also, the submucosal fibroids specifically and the fibroid polyps, they present with intermenstrual bleeding. And there are certain fibroids which also, the similar kinds also can present with dysmenorrhea and of course the reproductive dysfunction in the form of infertility, subfertility, and obstetric complications as well. So cause of pain in fibroids are basically the submucosal fibroids is a big culprit. They could be painful intercourse. And even there are certain situations where the fibroid degeneration or torsion occurs, which can lead to pain in the case of fibroids. As far as the imaging techniques go, the standard is our good old, transvaginal ultrasound, which is the imaging modality of choice. But believe me, we need to go protocol-wise, where we need to do a good transabdominal scan, as it provides us with a good overview of the entire pelvis. So before we begin or after we finish a transvaginal scan, it is always mandatory to examine the lady transabdominally, apart from doing a good transvaginal scan. Yes, you do have good armamentarium of 3D, 4D. Now the AI has come in, and then coronal view, which we'll see how AI has really helped us in mapping the fibroids. Then, of course, various display modes on 3D, which help us to bring out the details of the fibroid mapping and the presence of fibroids. Color Doppler, many a times it helps us to look at the vascularity and differentiate from other myometrial lesions. And of course, at times, we can use a very good tool, which is an office procedure, which we can do by just injecting saline into the endometrial cavity and bringing up the images for excluding the presence of the fibroids, and also doing a 3D reconstruction for that. MR does help, but believe me, you must trust your ultrasound. So to begin with, the Bible, which we follow by looking at the fibroids, we follow what is called as Musa. Well, the term Musa means that this is an opinion, consensus opinion, which comes from a morphological ultrasonographic assessment, which tells us that we are supposed to use certain terms and definitions to describe a fibroid, so that if I say that I'm looking at a Labrador, so it makes the same information and the message goes to your brain that, well, that is the Labrador which I'm talking about. So you need to be at the same page with the clinician here as well as overseas or in India. So that this group gave us the terms and definitions to describe the fibroids. Now let's look at the features and the terms and definitions. So in the features of fibroids, we will talk about ecotexture, we'll talk about the margin, talk about the shadowing and the vascularity pattern. When we talk of ecotexture, this is normally a fibroid is uniformly hypoechoic lesion, which is seen, and it could be also isoechoic. Now, when do we say hypo and when do we say iso? It depends upon the comparison of this lesion with the adjacent myometrium. So that is important, because we need to know if the fibroids are more echogenic, that means they are holding a lipomatous component and they are going to be echogenic in comparison to the adjacent myometrium. Secondly, they could also show you a non-uniform mixed echogenicity, right? Where you could have non-uniform pattern, well-circumscribed lesions, but showing you echogenic component, right? Or they could show you a non-uniform cystic component. So these are the various echotextural patterns of the fibroids which we see, which are called as the typical ones. Let me tell you, they are easy to diagnose, but when it comes to the atypical ones, it really causes a pressure in us to make sure that it is a fibroid, correct? Then talking about the shadowing pattern. So the shadowing could be either the edge shadowing, as we see in this case, or could be a mixture of an internal and the edge shadowing, or could be a fan-shaped shadowing, which happens to be seen when you see the completely calcified fibroid. So these are the various types of shadowing. I've talked about the ecotextural pattern, and now coming to the margins. The margins are well circumscribed. Remember, each and every point which I speak makes a lot of sense, because this is how we need to describe it in our report on day-to-day basis. So make sure that you take the image in both the longitudinal as well as the transverse plane, right? To make sure that the entire margin is well circumscribed, and you rotate the probe as I told you, and also make sure you have the vascularity, switch on your color boxes, and you see the pattern of vascularity, and you will see that the fibroids generally show you predominantly a pericapsular flow, which delineates the margin of the fibroids. Then it needs to be measured in the 3 orthogonal dimensions in 2 perpendicular planes, as you do it for other lesions on ultrasound. Talking about the vascularity, here the power Doppler shows you a peripheral. Make sure your color Doppler settings and power Doppler settings are correct. Always use a PRF of about 0.3 to 0.6. So that's a good PRF for a gynae imaging. So once you talk of peripheral vascularity, it is that's the normal tissue which is seen around the fibroid, which is compressed and is showing you a pericapsular or perilesional circumferential flow. Also, the vascularity helps you to delineate the organ of origin when you have a lesion beside the side of the uterus, and it's a good idea to make sure that it's arising from the uterus, and that can be performed by using your power Doppler and showing the organ of origin. That means there will be a vascular pedicle which will be seen arising from the adjacent uterine wall and going and approaching towards the fibroid. So that means that it is a pedunculated fibroid. So you make sure that this is uterine in origin other than extrauterine origin. So vascularity helps in that process. Also, it delineates the presence of a subcaps or the pericapsular flow as seen in this submucosal fibroid, telling you that there is an absence of what you call as the pedicle artery sign, which is seen in endometrial polyps, and what you see on power Doppler is a ring of vascularity. And this helps to differentiate, brings the diagnosis more narrower. Then you have a mild intralesional vascularity at times you may be seeing, or there may be an extensively increased vascularity. But remember one thing which is very important, predominantly apart from the mixed echogenic vascular pattern of the fibroid, which includes looking at the perilesional and the internal vascularity, the differential most important thing is predominantly the fibroids will show you a pericapsular nature of flow, as against the adenomyosis, which will show you random distribution of vessels without any pericapsular rim. At times, a focal adenomyoma may be difficult to diagnose. But let me show you on power Doppler, the next slide, the subsequent slide, of course. This is just to show you, since we are talking of adenomyomas, it is very important to differentiate a fibroid from an adenomyosis. Now, the adenomyosis is basically a disease which arises from the endometrium. So since it arises from the endometrium, you will have an indistinct border of the endometrium, one. And whereas the leiomyoma is predominantly myometrial in origin, where the borders of the myometrium, the EMJ or the junctional zone, will be completely well defined, though it may be distorted by the surrounding fibers. One. Secondly, calcification is not a feature of adenomyosis, whereas in a leiomyoma, you may or may not see a calcification. Second, the borders of the adenomyomas are generally adenomyosis are indistinct, right? It's a myometrial invasion by the endometrial tissue. So you will not have a distinct margin in adenomyosis, whereas in a leiomyoma, the margins are very much distinct. Shadowing is a feature of both but how to differentiate. Whereas in adenomyosis, you have a typical fan-shaped shadowing, Venetian band shadowing, whereas in leiomyoma, you will have edge shadowing, and also you may have internal shadowing. So that is one differentiate, because doesn't have a wall, adenomyosis, so will not show an edge shadowing. So that's one important thing. And of course, the location, you know that adenomyosis, as I told you, is a submucosal area where a submucosal lesion or abutting the mucosa, abutting the endometrial lining, whereas leiomyomas can be either submucosal, intramural, and subserosal. And as far as the vascularity pattern is concerned, I have already explained you the adenomyosis will show you a translesional vascularity as against the leiomyoma. So just to show you a video clip, which I just took a day back, where I showed you, this is a bulky uterus. The lady has an adenomyosis, a focal adenomyoma. The most important thing was that she was holding an endometriotic lesions, both ovaries. That's the reason why the endometrial cavity is spared, and what you have is an adenomyoma, which is seen more towards the serosa and involving the mid part of the myometrium as well. And as you see, you do not see a pericapsular ring. You see a translesional penetrating vessels. Wherever the endometrium goes, it follows that particular path. So this is to show you an adenomyoma, which is seen to differentiate this is how you differentiate this entity from fibroids. So at times, this could be confusing. So there has been a paper where they have actually given us the vascularity score of leiomyomas, where the score 1 is no vascularity, 2 is minimal, 3 is moderate, and 4 is an abundant vascularity seen in the fibroids. As far as the classification is concerned, the FIGO, the MUSA, in fact, the MUSA consensus statement has put forth a FIGO classification, which is based on the relationship of the fibroids with the adjacent endometrium, myometrium, and the serosa. And accordingly, we have about 8 types of classification. The 0 means that the fibroid is completely intracavitary and is pedunculated. And the 1 means that it is a submucosal fibroid which has less than 50% intramural component, whereas figure 2 also bears a relationship with the endometrium with more than 50% or close to 50% of its extension into the adjacent myometrium. Calling it as figure 2, whereas the 3 is an intramural fibroid which bears a relationship with the adjacent endometrium. It just abuts it, whereas the figure 4 is the one which is completely in the myometrium and does not touch the line, that's the endometrial line or the serosa, whereas the figure 5 is the subserosal fibroid, which has a very little component which is extending outside the uterine serosa, and the 6 is one which has a larger component is extending outside the serosa. And whereas the 7 shows a pedunculated fibroid with the peduncle, as I showed you, and this peduncle, when you slide upon these fibroids, they move. Right? So that's how they move, and how do you reach to them is the vascularity pattern, which I just showed you, of the fibroid will hold a vascularity from the adjacent uterus. And the other, the type 8 is the cervical or the parasitic. And the 2 to 5, we sometimes have large fibroids extending in the entire myometrium, which are called as transmural or called as figure 2 to 5, right? And the 2 indicates its relationship with the endometrium, and the 5 number relates its relationship to the outer serosa. Now, in that perspective, we move on to just the other classifications, where I just need to tell you that SK, that's European Society of Gynecological Endoscopy, has put forth for the submucosal, specifically for the submucosal fibroids, which count for 10%, and they help, actually this classification has been put forth to assess the feasibility of the hysteroscopic resection of the fibroids. And this is how they explain is when you have L0 means when there is no intramural component, it's completely intracavitary and is attached to the fibroid by a pedicle. And L1 This is L1, which is less than 50% of the fibroid extending into the myometrium. And then if you just draw an angle with the fibroid with the adjacent cavity, will produce an acute angle, whereas L2 will have an obtuse angle because they have a wider mural component. So this is basically to assess the submucosal fibroids, and I'm sure that when you talk of infertility, they really are of big help. And then the LASMAR, that is gave us another classification in the year 2005, which tells us that step W, they've given us the, what do you call the?
Mnemonic.
Mnemonic, yeah, correct. Step W is where you have S denotes to the size, T denotes to the topography, E is the extension of the base of the myoma, and P into penetration into the myometrium, and wall is the which wall does it involve. So each parameter will give you a sum of a score, right? The score, finally the score comes, that will decide with the complexity of the therapeutic procedure. So this is why these are the various classifications which have been put forth, is because they will help you to counsel the patient very well. They will tell you which type of procedure you have to go for, whether it's a hysteroscopic removal or whether you are going for a laparoscopy. So that I'm being a radiologist, I think the gynecologist would know better. And similarly, the score has been provided, and that gives you the type of the surgeries which are required for these particular scoring. Now, how do we do as clinicians, as radiologists, how do we actually map the fibroids in day-to-day scan? So why do we map the fibroids? We need to not only map the fibroids and try to locate for the location, we also count the number. We also try to measure the size of each fibroids, give the morphological characteristics of the fibroid. As I told you, hypo, iso, hyper, mixed echogenic, or mixed echogenic, predominantly hyperechoic. All these things need to be handled by a radiologist, whether there is shadowing, whether there is calcification, what a kind of vascularity. So all the ultrasonic morphological characteristics needs to be explained. Then also we need to tell the clinician that how much is the distance of the fibroid from the serosa or the endometrium, because this is very, very important, right? And a relevant 2D, 3D should be attached. In fact, I make those reports, I draw the diagram for the clinician because it becomes very nice, which I'll show you in my subsequent slides. So this all information is important to strategize management and assess the surgical approach. So how do we go about it? There are four most important factors. One is how superior is the fibroid? Is it in the fundus? Is it in the upper corpus, mid, lower, or in the cervical region? Next question, is it on the right side or the left side? Next question, or in the middle. Then comes, is it in the anterior wall or in the posterior wall? Then comes, how much is the distance of the fibroid from the adjacent endometrium, and how much is the distance of the fibroid from the serosa? And also give you the volume of the fibroid. Then the ideal time to map the fibroids is during the secretory phase. Why? Because you have a good contrast with the adjacent hyperechoic thick endometrium, and you are able to map the fibroids more diligently and more crisply. Various modalities of mapping the fibroids are 2D, 3D, saline, and MR. But fibroid mapping, when it comes to reality, for example, in this particular patient who has an enlarged uterus and there are multiple fibroids, there's sometimes very confusing. Well, where is the endometrium? What am I looking at? I'm just looking at fibroids. How am I going to look at the endometrium? Because mapping of the fibroids is always in relationship with the endometrium, correct? And then how do I do it? So the most important thing is try to trace. If you're in a mess, please follow the cervix, follow the cervical canal up to the endometrial canal, and that will help you to guide the endometrial canal. And then you can actually see the relationship of the fibroids with the endometrium. So that's one most important thing when you are coming across such big uterus. Another thing is 3D. We do it routinely, like we do it as seen in all these images. Right? You're looking at a submucosal fibroid. That's a submucosal figure 1, which is showing you more extension, and 2, an intramural fibroid, which is abutting the endometrial lining. And that's a subserous fibroid and a large transmural fibroid. So 3D has brought us magic, let me tell you. This coronal view, especially the C-plane, right? And if you do it every day, it becomes a part of your habit. So coronal plane helps you to assess the fibroids in relationship to the endometrial cavity. And today I introduce this modality, which is called as AI, right? This is a new equipment by Voluson, expert, which tells you the greenish thing is the uterus, the blue is the endometrial cavity, the red are the fibroids. It can tell you the location, the number of fibroids, and also bearing the relationship with the endometrial cavity. Sorry. Okay. So yet another, you can use your infusion, saline infusion, where you've seen I'm performing a saline infusion. You can bring out a large, fibroid, which was, not discernible on the routine ultrasound. So patient is symptomatic. It's just the fluid, saline. You just have to inject a bit of it and there your answers are. You may perform 3D or not perform 3D is separate, is absolutely separate. Good 2D is perfect. Please do good 2Ds, right? And then this is my habit. I draw the diagrams. I tell the clinician, okay, on transverse section, I'm seeing so many number of fibroids. They're located in the anterior wall, more or less on the right side or left. What is the situation on the LS? Because this becomes very easy for the person to operate. So in the reporting of the fibroids, you say about the number, size, location, morphological, give a diagrammatic representation for these in sketch a diagram for them. But detailed fibroid mapping and diagrams may not be essential for asymptomatic women or those who are postmenopausal or those who do not desire fertility. If uterus is completely riddled with fibroids, as I show you, just the few ones which are relevant can be measured and given on a mapped form. As far as the MRI versus ultrasound is concerned, ultrasound is equal to MRI. Being the primary tool, you can't have a patient going for MRI every time for a routine scan, right? And then MR, no doubt, has a highest sensitivity and specificity, but it cannot be performed in a day-to-day basis. And only when we recommend, or these are the statistics, which have been provided in papers where they say if the uterus is more than 375 ml or there are more than 5 ml, then, but it all depends upon if you're a good expert on ultrasound, more than 5 myomas, I'm sure you people can locate. So trust your ultrasound, right? Let's have a look at the cases. This is a case, comes to me for a polymenorrhagia, dysmenorrhea for the past 3 months, and I'm sure you're looking at a submucosal type of a fibroid, showing you the typical vascularity, all the features of this. And we went in and did a 3D view, and that was the Omni view, which I have taken, right? And tells me the relationship of the fibroid with the endometrial cavity. Also, we need to check the distance of the fibroid from the serosa, and you see it is extending right up the serosa. So anybody going hysteroscopic removal can, have a high chance of perforation. So please, these are important things. You are supposed to give the measurement of the fibroid from the serosa or the internal lining, right? That's very, very important, right? Then how do we do it? How do we do the fibroid mapping? So one line is drawn from one endometrial myometrial junction to the other endometrial myometrial junction, and another perpendicular line is transected through it up to the longest diameter of the fibroid. Then we see which is more, A or B. So B is more, and we say that this has a larger mural component. So making it as figure 2. Let's take another example. 3D reformatted image of submucosal fibroids. 1. That's the endometrial cavity. Draw a line. Am I okay, doctor? Am I okay?
Yeah. Yes.
Okay. So we draw again line from one endometrial myometrial junction to the other and draw a perpendicular line. So here we see that this portion of the fibroid is less as compared to this. So that means what we are talking of is a figure 2, more mural component, other than looking at this. Again, we draw a line and the portion of the fibroid extending into the cavity is much more and making it as figure 1. So telling us that submucosal fibroids can be graded into completely grade 0 when we find it completely within the cavity, and grade 1 and grade 2, or we say it figure 2 or figure 1. Then this is a 45 years old gravida 2 coming with intramenstrual bleeding and holding an inconclusive reports, many reports, underwent biopsy twice for hyperplasia. what do we see? We see that this is a uterus. We see something which is within the endometrium and also extending to the endometrial canal and actually going into the cervical canal. Am I correct? Yes. So, and when we did 4D VCI, we performed, and the things became a little more clearer than the grayscale. We saw that this was an echogenic long lesion, predominantly echogenic lesion, right? And showing you an extension within the myometrium has breached the anterior EMJ and extended into the endometrial cavity and the cervical canal. That means it tells me that the fibroids will follow the path of least resistance. So similarly, 3D reformatted image showing you a myometrial component of this lesion and also extending into this. And the vascularity was color score 4. And this was the grayscale, the gross anatomy of the uterus, cut open uterus, showing you a large fibroid polyp. So this is how you need to approach a fibroid, right? Another lady comes to me for a 42-year secondary infertility. I mean, if you do not put fluid, you cannot make out what is happening. So I went in with agitated saline. That helps me a lot. You can agitate it outside. You can use 2 syringes and with a stopper stopper in between, 3-way stopper, and you can agitate the saline, and this is the agitated saline. Can you see the bubbles?
Yes, yes, yeah.
And you can outline the entire fibroid. In fact, agitated saline makes a beautiful contrast for the tubes and gives you, you don't need to use your hycosine, no contrast use. You can do it with agitated saline. It brings up the entire tube, the interstitial segment, and the rest of the tube beautifully in the adnexa. So that's, of course, reassuring. You are using your Doppler, you are using your 3D, and that tells you that you are looking at a submucosal fibroid. Another patient, of course, we did have a large fibroid. This was not predominantly because of that. It was we trying to locate some other lesions in the cavity. We had introduced saline, and that's how, again, the fibroid, large transmural fibroid. Again, we draw a line from one endometrial junction to the other. Then again, we draw a line, and you see the predominantly the component of the fibroid lying outside is much more. Then this is a very interesting lady. Girl comes to us presented with sudden vaginal bleeding, accompanied by severe pain, nausea, vomiting, and fleshy tissue she felt at the vaginal orifice. Now, as she felt a fleshy tissue, she had acute pain, right? Acute pain, nausea, vomiting, correct? So this was a large leiomyomatous polyp, which was arising. You can see the pedicle, the vascular pedicle arising much above the uterus. And that was the vascularity which was seen extending to the entire polyp. And also, you could see there's a myometrial depression telling you that I was looking at a partial inversion of the uterus. And there is also a depression along the myometrium, and this was the inverted segment of the uterus. So this was a case of a partial partial inversion of the uterus due to the presence of this large leiomyomatous fibroid. So this was the leiomyomatous polyp which caused this particular entity. This is just a uterus which you see day in and day out. That's the fibroid producing what is called as abutting or having bearing in relationship with the endometrium. We call it as Figo 3. Now, my question is that does intramural fibroids, the ones which are not distorting the cavity, do they cause infertility? Well, type 4, they do not cause because they are seen within the myometrium. But there are some controversies about type 3 because they interrupt or they abut the EMJ, correct? Now, once they abut the EMJ, they increase the uterine peristalsis and contribute to miscarriages and preterm labor as against the type 4 ones. And if they are certainly larger than 3 centimeters, they are a cause of infertility. So hysteroscopic removal of type 2 is suggested if all other causes are ruled out. This is actually type 3. Sorry for the mistake.
Madam, can we shorten it a little bit since
Oh,
yeah.
I'm going to finish. So
Yeah.
this is another, I was thinking of actually. So this is another transmural fibroid, the lipomatous one, which is seen, and a large fibroid, and you can on transvaginal, you see a predominantly echogenic lesion, and this was the gross anatomy. So, and this was another transmural fibroid, which you can see on a 2D, 3D, and that was showing you a whirling pattern. Coming to the last, that is a subserosal fibroid. These originate from the myometrium, and they may have a broad base or a broad pedicle. And this is just to show you a large fibroid, which showing you a lot of I mean, she had come with an ovarian mass, right? But this was the fibroid, and we could see the vascularity, as I showed you, the pedicle sign, which was arising from the fibroid and extending to this particular cystic mass, and that was a degenerated fibroid. And the same has been
Degenerated fibroid.
yeah.
Degenerated fibroid.
And another degeneration fibroid, and basically this is the hyaline degeneration.
Hyaline degeneration.
Yeah. So I think we come to the end, because I was going to take up leiomyosarcomas, but certainly it is a topic in its own. Thank you so much.
Thank you so much, madam, for the wonderful information. That was a very detailed explanation of the imaging modalities of fibroid. I request Dr. Chandra Punasamy, madam, to give her expert opinion and conclude.
Yes, thank you, Dr. Kaur. It was an excellent and lucid presentation. And you showed all ultrasound pictures and you made magic and through your slides. And you gave the take-home message that what should be a proper radiological ultrasound report, which will lead us to a very, when you go for surgery, we can go with a clear mind that what should be done in a proper way. So it was an excellent thing. And actually, we missed that leiomyosarcoma because of time duration. We may, next time we will meet and we can have a lecture from you. And it was very nice. And you showed how to proceed with ultrasound and 3D and everything. And the saline infusion was excellent with this agitated saline. And we learned a lot.
The same can be handled for the tubes. That can be a very good modality. Patient comes to here, you can do both the things right away, and that will delineate the tubes very well, because it's the air. So it will be a beautiful contrast beside the adnexa. So and then you don't need any contrast. It's not expensive. It's just the agitated saline which we use.
Yes, we have learned about it, but we are not applying it. Once you showed it, no? So from today onwards, we can apply it and we can see it. Wonderful. And thank you very much. And thanks IFS South for the wonderful opportunity to chair this session. Thank you.
Thank you. Thank you, madam.
Thank you, madam. Now, I'd like Dr. Rashmi Ajit to introduce our next speaker, Dr. Kuldeep Jain. Rashmi Ajit, ma'am, are you there?
Yeah, I'm here. I'm here. Yes, madam.
Yeah.
Yes. Hello.
Hello. Yeah, ma'am. Can you please introduce our next speaker, ma'am?
Yes, madam. It is a great pleasure to introduce our next speaker, Dr. Professor Kuldeep Jain, Director of KJ IVF Center and Laparoscopy Center, Delhi. He has many important positions and achievements to his credit. He is the former secretary and past president of IFS, chairperson of the International Exchange Committee IFS, and he's editor-in-chief. He's instrumental in conceiving and introducing multiple projects in IFS like ESHRE, preparatory course, educational fellowship programs, affiliation to Amity University, IUI workshops, etc. He was a chairperson of the Endometriosis Committee of the FOXI from 2016 to 19. And he's a chairperson of the Infertility Committee, AOG, member of Endoscopy Committee, and he has delivered more than 400 invited lectures and orations and has received a Lifetime Achievement Award, IFS Appreciation Award from IFS, IMA, FOXI. Over to you, Professor. We would love to hear from you.
Thank you. Thank you, chairpersons, for your kind introduction. This is really a pleasure to be speaking on this platform because of many reasons. It is a IFS program who has been progressing very, very fast. And I am always proud to attend any IFS program because I am the founder secretary and past president. Another thing, I am mentor of IFS Endoscopy, and this program is associated with that. So really a wonderful opportunity to learn and combining two SIG is a great idea, I think, because ultrasound and surgery is they go hand in hand. If a ultrasound is not done properly, a surgeon cannot do much, and the same vice versa. So it has to be a close coordination between two. I will be speaking today on how to tackle, like to share my experience, how to deal with the myomectomy, especially in those cases who are looking for a child, because it is a conservative surgery and you have to repair the uterus at the end of surgery. Otherwise, it may not be very beneficial. So, keeping that thing in mind, I will try to give few important take-home messages to our audience, and I am sure that will be helpful. Can you see my slides?
Yes, sir. Yes, sir.
Yes, sir. Yes, sir. It's visible.
Okay, so let us start from beginning. I congratulate the organizer. Ritu Khanna has done wonderful job bringing two SIGs together. So congratulations, Ritu.
Thank you.
I bring greetings from my center. This is my birthplace, and I invite all of you who visit Delhi to visit the center. Previous lecture, Dr. Ladvans has beautifully highlighted few points which are really important. We keep on seeing multiple classification, but how to use these classification in our clinical practice, that is more important. And whenever you are trying to go for a myomectomy surgery, myoma surgery, very important is to locate them, and these classification, they always help in deciding the route of the surgery. So that is how these classification becomes very important. But unfortunately, when you see the ultrasound reports, Dr. Ladvans has beautifully highlighted how the reporting of fibroids should be done to help the clinician. But unfortunately, when we see the report, 90% of the reports, they are not written properly. And one important take-home message is whether you are yourself doing the ultrasound or you are getting it out, the ultrasound from someone, it is very important that as a surgeon, you must know the classification, location, number of the fibroid, so you can decide. It should not be surprising on the table. So you should not have any surprise. And it is always suggested that as a surgeon, you must know to do ultrasound also. This is my practice for last 35 years. Before putting a knife, I always do ultrasound myself. But it may not be possible for everyone, but a close coordination is really required. Another classification, this is for basically hysteroscopic resection, whether you can do the histoscopic resection or not. So these classification, they really help in deciding how to manage these fibroids. This is another classification, step W classification, which goes beyond the previous classification, and you can see the site, topography, extent, whether it's anterior or posterior, lateral. So this tells you exactly the topography of the fibroid, and this really helps in making the decision, and this can be used in the management protocol. Like this is a scoring system which you can use, and once you score the fibroids before, can I have silence, please? So if you are having a fibroid which scores less than 4, it is easy surgery. Low complexity histoscopic myomectomy can be done with patient who is scoring less than 4. 5 to 6 is slightly highly complex histoscopic surgery, but can be managed by experienced surgeon. But if it is score is more than 7, then usually histoscopic myomectomy is not indicated in these patients, and one should, even if a large portion of fibroid is in the cavity, one should approach it through the laparoscopic route. So that is how this classification helps you in managing these fibroids. Now, anything in the uterine cavity is to be removed, whether it is small or big. That is what I believe, and that is also the recommendation, that if a fibroid is distorting the cavity, even if it is small, that should be removed. Now, there is a very thin line between the submucosal polyp and fibroid, and usually that is confirmed when you try to palpate it by your forceps, or when you send it for histopathology. Then only diagnosis of endometrial polyp or submucosal fibroid can be confirmed. So anything which is in the cavity is to be taken out, and these small multiple polyps or fibroids can be easily tackled by your microseizure. Problem arises in those small polyps or fibroids where they are coming end on. You can see it is fundal fibroid, a small fibroid, but it is fundal, so you cannot see the base. And if you cannot see the base, you cannot do the resection. So in these type of patient where the base is not visible, you have to use your scissor when you are cutting to lift the fibroid, so you can start seeing the base. And as you dissect, you again lift and give a small cut. So a small nick is to be given at one at a time, and you have to remove these small multiple fibroids, especially those which are in the fundus and in the cornu. Again, this one is in the cornu on the left hand side, and if you are not able to lift the fibroid, if it is a bigger, then many times it becomes a little difficult. So then you start resecting, because these are small polyps or small fibroid in submucosal. So it is easier, but if it is a bigger fibroid, then you cannot just lift them, and in those cases you use current, resectoscope is used, and you start resecting from whatever point you are able to approach the fibroid. So these are some of the tricks of using the small, removing the small fibroid. This is another video where the whole cavity is filled with multiple small myoma. They are broad-based myoma. They are very soft. So it could be a polyp, it could be a degenerated fibroid, but that is confirmed only when you are sending the tissue to histopathology. But see here, it is a cotton candy type appearance. When you give a nick, it is cotton candy type appearance, and there are more of the fibrous to a muscular tissue than endometrial tissue. So it is a fibroid, and as you go on resecting, the fibroid is coming out from the myometrium. So, and it is very broad based. Now, why I am using the scissor here? Because when I touch the this fibroid, it was very soft. So, if it is soft, you can use the scissor. Otherwise, you have to do the use the resectoscope. Usually, in those cases where it is very broad-based fibroid, you must remember that you should try to avoid the destruction of the healthy endometrium. Otherwise, the chances of having intrauterine adhesion will be more. So they are very small fibroid, easy to remove, but they are multiple, and it will cause lot of scarring if you are using lot of tissue, normal tissue. So here again, now this is the end of the picture, and most of the time, actually this is not classified anywhere, and this is requiring a correction in the available classification.
Sir is disconnected, it seems.
Some network issue, I think. Maybe he is joining again or something. Sir is there.
My slides were missed, so I will again share. Okay, so like these are the fibroids which are very difficult to manage because they are very small and having a very large base. So this is when the base is very large and it is a small fibroid. This is the flap method which I use. What I am doing, I am giving raising a flap in the endometrium at one point and enlarging it on the both sides, and the fibroid is scooped out behind this flap. So there is no loss of the endometrium at the end of the surgery. So here you can see I have raised the flap here, and this is the fibroid inside, and I am scooping out by use of a monopolar hook, and this is scooped out. And at the end of this myomectomy, you will see that this flap which is raised, this will cover whole defect. So there is no defect at the end, and this gives a very beautiful endometrium at the end of surgery. And when you follow these patients post-operatively, there is no scarring, and even the vascularity is not compromised. So here you can see, appreciate very well, the endometrium is covering the defect, at the end of surgery. Now, another fibroid which is very large needs to be tackled by laparoscopy, and when it is a single fibroid, it is easier. When you are dealing with the multiple fibroids, very important point which you need to remember that when you are dealing with multiple fibroid or a large fibroid, it should be mapped very accurately, as was told in previous lecture. Mapping is very important. Without mapping, if you start doing myomectomy, you will be doing more harm than good. Once you know that how much is the depth of the fibroid from the serosa, it is easier to find a plane. So always when you are doing a ultrasound, always measure the distance of the fibroid from the serosa. So when you are giving a nick, you are able to find a plane very easily. Another important point is when you are putting the vasopressin. Vasopressin is very important drug which is really helpful in reducing the hemorrhage and reducing the bleeding during the myomectomy. It is not a rocket science, but if you are not doing it correctly, then it becomes messy and the complication rate becomes very high. So try to find the plane first and then start doing the myomectomy. Many times people start doing the dissection very fast and they enter into the wrong plane, and that is why there is a lot of bleeding when you are entering into the wrong plane. Now, second important point here, when you are dealing with the large fibroid, you must use 4-port rather than 3 ports. So 2 ports should be used for myoma screw. So you can just lift the fibroid in the right direction. Important point is the traction. Traction should be at the right point, right amount, and in the right plane. So if these 3 things are kept in mind, then you can dissect the fibroid very easily, even if it is very large. As far as the size of the fibroid is concerned, number of the fibroid is concerned, it is not very important how many fibroid you can remove by laparoscopy in one sitting, or how large fibroid you can remove. It is the technique. If you are using a correct technique, complication and the by the same technique. Try opening the cavity. Now, many people, they are very afraid that try to avoid opening the cavity, but if the cavity is open, just suture it properly. At the end of myomectomy, you should be able to avoid any dead spaces, any collection. That is very important. Any hematoma in the stitch line is not warranted. So try to avoid uh, creating dead spaces when you are doing the suturing. And at the end of surgery, try to see if there is any bleeding. You have to uh, control it before closing. This is the end picture. now suturing has become very easy now because of the availability of the barred suture, and you should try to suture in such a way that the strength of the suture line is maintained. If you are dealing with multiple fibroid, then try to avoid from multiple sides. You have mapped it properly and planned your uh, incision properly. Now, this is a case which was opened as fibroid. So, here you see, it looks like a fibroid, but the patient was having a lot of pain. And on ultrasound, it was not a clear-cut echogenicity as you get in fibroid. There were areas of hypoechoic nature in the fibroid. So when we started operating this fibroid, it was just easy, but as you started separating, there was a collection inside you can see here, this was a collection of blood. So it was not a fibroid, it was adenomyoma, which was collecting in the inside this adenomyoma. Blood was collecting inside, and when you are dealing with such type of situation, now here it is a cavity. The traction is not very good, and in adenomyoma, there is no capsule, so you have to create the plane. There is no plane here, and that is how it is different from myomectomy surgery. So you have to create the plane and scoop the adenomyoma. This is a small adenomyoma, so it's not very difficult. But when you are using a doing the adenomyomectomy in a large uterus, again, it is very important to map how much you are going to remove, because there is no demarcation as such, and you are removing actually the myometrium. Okay. So how much myometrium is to be removed when you are doing adenomyomectomy, that needs to be planned beforehand. Like in this case, here you can see this is a large adenomyoma. Again, the diagnosis of myoma or adenomyoma needs to be decided beforehand. But many times you are thinking you are doing a myomectomy, and when you go, you don't find a plane. And actually it is a adenomyoma. The adenoma, you keep on dissecting, it is just a thick myometrium which comes out, and there is no plane. Now this is very huge adenomyoma, around 18-week size uterus. And in these cases, when you are doing such type of surgery, it requires little more expertise than the myomectomy, because there is no plane. So you need to create the plane. Again, the technique remains same. In adenomyomectomy, the vasopressin doesn't work very nicely, so the amount of bleeding is more. 2-3 things you need to remember. You need to map how much you are going to remove. At least 1 centimeter seroja on serojal side and 1 centimeter towards the endometrium side. That much you should leave. Because when you are doing such large adenomyomectomy, many times you don't realize that you are removing more than required, and there is no tissue left for suturing. So that's why it is very important to plan your adenomyomectomy in such a way that for suturing and for getting the strength of the uterus at the end is available. This is another important video. This is degenerated broad ligament fibroid. Now, in broad ligament fibroid, there is only one important thing because it is in the broad ligament. So there are a lot of important structures which you need to take care. Like on medial side, there are the uterines which needs to be tackled. On the lateral side, there is the ureter. So before starting, you must see that how far is the ureter, and you should stay away from the ureter. And in between also the section, you need to see whether you are not going to damage the ureter. Like in this case, because there is no myometrium around, so the scooping of fibroid is easier, but on the other hand, it is a degenerated fibroid, so the traction method is not very good here because of the degeneration. Now on the when you are reaching medial side, it is always good that you use a bipolar to separate the base from the myometrium. Otherwise, if you keep on dissecting, then you might cause more vascular injury. So I always use the bipolar when I reach near the pedicle. Okay. So that is important trick when you are doing a broad ligament fibroid. Now, prognosis of myomectomy depends on severity and grading. What is the tissue characteristic, volume of cavity involved, quality of adhesions, thick or thin, and visibility of ostia in intracavitary fibroids. So that was all about the myomectomy. I take this opportunity to invite all of you to this great event which is coming in your way in September. This is an international conference which is brought by SRA, ISAR and IFS together. So I hope that everybody is aware of this conference and you have blocked your date, you have done your registration. If not done, please do, because this is a conference which is just like best of SRA and ASRM. This is first time the European society is coming outside their terrain. They have just gone to US and now they are coming to India. So please take advantage of this conference. We will be having more than 16 SRA top-notch faculty to interact with all of you.
Thank you so much, sir.
Join us. There is an announcement from SIG Endoscopy. Please join the group to get more information on the academic activities. Thank you very much for your patient hearing.
Thank you so much, sir, for the wonderful information on and different cases on the fibroids and adenomyosis. I request Dr. Umam, madam, to give her expert opinion and conclude this session.
Thank you, Priyanka. I think expert opinion with among the stalwarts, I think I would do the justice. But I just, whatever Dr. Kuldeep sir has said, I just will summarize it. I mean, first of all, the most important thing is like your imaging is what is more important. It's needed before you put your knife to the skin, which rightly said by you, sir. And depending upon where the fibroid is or where your adenomyosis is, you take precautions. For if it is a lateral broad ligament fibroid, you know your anatomy, know the structures which you need to avoid, and know your limitations, your expertise, and then do the procedure. And hysteroscopy, I enjoyed the point that saying whatever comes into the cavity, take it away. before putting your embryos in. That was a well said point, sir. Even though it is small, that could still affect the implantation. And hysteroscopic myomectomy, I think it is a beautiful procedure, but to understand whether you're going to do it hysteroscopically or laparoscopically, depending upon your mapping, all comes to the mapping at the end. And about the adenomyosis, yes, sometimes I've burnt my fingers thinking that it's a fibroid and then gone in and then was surprised with your old blood collected inside. And adenomyomectomy is not easy. Myomectomy is easy, but adenomyomectomy, you have to be very, very careful. And leaving a bit of adenomyotic tissue is much safer than trying to be more vigorous. Thank you, sir, for all your beautiful points, whatever you said. Thank you.
Thank you. Thank you. Thank you for your comments. Yeah.
Yeah. So,
Any other question? I will be happy to answer.
There is just one question from Dr. Pallavi. She's asking, 1.5 centimeter fibroid just below the endometrium should be removed before embryo transfer?
Yeah, very, very good question. Actually, it is not the size, it is the location which is important. And if it is touching the endometrium, it should be removed. And how to remove, I just showed one flap method, because it is very difficult to find that small fibroid which is you are seeing on ultrasound. So you just see a bulge and start raising a flap, you will find that small fibroid. And if you are having a 3 centimeter fibroid in the myometrium, it may not be requiring removal. But if you are having a 1 centimeter fibroid near the junction of endometrium and myometrium, that may really hamper the implantation. So it should be removed, yes.
So,
Thank you so much,
one
sir.
question. Before taking up on this such a large adenomyoma, do you suggest, do you do any preoperative GnRH injections, anything to reduce the size or any medical adjuvants?
No, preoperative, usually we don't suggest any medication. But after removing the adenomyoma, we usually give 3-4 months of GnRH analog and then transfer. So that gives a better outcome than using only surgery or using only GnRH analog. So when you combine both, it gives a better outcome in larger uterus. Yeah.
Thank you, sir.
Yeah.
Thank you, sir.
So thank you very much, everyone, and I hope you enjoyed some take-home messages. And I again request all of you to join at Fusion. Thank you very much.
Definitely, sir. We'll all definitely try to use this opportunity to join that session, that conference. I thank all the chairpersons and the speakers for this wonderful session. Moving on to the next session, we move on to the panel discussion on tackling fibroids. I invite our moderator, Dr. Ritu Khanna, to introduce our panelist, ma'am.
yeah. So thank you, Priyanka. We had 2 fantastic deliberations, and I think, we had so much of learning. And from tomorrow, I think will be better, to be on ultrasound machines and to be VR scopes where we are going to use. We had so many tips of how to map them and how to proceed. So now we have a fantastic panelist with us who are all experts in their field and are going to drive us well through, the different cases, how we're going to move about with them. So we have with us Dr. Gayatri, who is Consultant Obstetrician, SMS Hospital Medical Director, Hari Fertility Center, and Secretary, Tirunelveli Foxy Association, and with a special interest into high-risk obstetrics, infertility, hysteroscopic preventive obstetrics. Welcome to you, Dr. Gayatri.
Thank you, ma'am.
We have Dr. Archana Ambojan with us, who's Fertility Specialist and Director, Omega Fertility Center, Sundaram Arulhaj Hospitals, Tuticorin. She's the Vice President of Tuticorin Obstetric Gynec Society and been a speaker at so many conferences and conducted a lot of CMEs and workshops. Welcome, Dr. Archana. We have Dr. Jaya Chitra with us, who is a consultant obstetrician, gynecologist, and fertility specialist, Nithila Nursing Home, Madurai, and also is the treasurer, Madurai Menopause Society. Welcome, Dr. Jaya Chitra. Dr. Mansi Jain, who is a diploma in clinical ART, fellowship in reproductive medicine and surgery, and is a consultant reproductive medicine and gynec endoscopic surgeon at KG IVF and Laparoscopic Center, and is also the co-convener of the SIG. So welcome, Dr. Mansi Jain. Dr. Uma Brinda is the secretary, Thanjavur Obstetric Gynec Society, and is an executive member from the South Tamil Nadu chapter. Welcome to you, Dr. Uma. Dr. Nivedita is the co-founder and consultant and Pranaya Specialty Hospital and Yatush Fertility Center, Theni. She's done a fellowship in reproductive medicine and assistant professor, Shri Muthukumaran Medical College, Chennai. Interest into laparoscopy. Welcome, Dr. Nivedita. Dr. Swati has a lot of interest into an advanced laparoscopy and histoscopy and is dedicated to exemplary patient care. She's done a fellowship in endogynec from GEM Hospital, Coimbatore, has been a speaker from so many conferences and has several posters and publications to her credit. So we have all our esteemed panelists with us. And now I would like to do my share screen to begin with the panel. Just a minute to do my share screen. Let's move forward to come to our panel. Can you see the screen, please? Yes. So we have been making a precision, we've done the surgeries, and now our panelists sit down. And we know why we took up this, because hysterectomies account 6% of major surgeries. And if you go to major common indication of hysterectomies, fibroid accounts for around 48%. There's so many things which decrease the risk of fibroids at parity, late menarche, and smoking and use of contraceptive. But there's so many questions into our mind, as we had few of us asking, do all fibroids need to be removed? Do asymptomatic ones need to be removed? Do all symptomatic need to be removed? Can there be a medical management, or is it really a cause of a patient being infertile, and is pregnancy really a high risk? So a lot of public situations up there, and my panelists are here to clear all of them. So we understand that individualization is the key to success, and this is the time to individualize ourselves. So we have this first patient who's a 20-year-old girl who comes with a little heavy menstrual bleeding since 6 months. That's tolerable, but significant dysmenorrhea, and sometimes she keeps having the lower abdominal pain. She's brought an ultrasound report which says that there are 2 interstitial fibroids, which are 12 into 14 millimeters and 10 into 12. One ovary is cystic, enlarged and echogenic, and the endometrial cavity is normal. Now, this girl is anxious with the tumor and said it could be something with the cancer, still not married, and she has an examination which she needs to undergo 6 months from now. So, Dr. Gayatri, now what are the investigations? Are you satisfied with this report as a treatment management they're going to move forward, or you want to still undergo certain other investigations? Dr. Gayatri.
Yeah, thank you. For this patient, I would first do a basic hematological workup, just do a hemoglobin, and also look at her thyroid levels, because she's saying dysmenorrhea. We need to also heavy menstrual bleeding, and we need to take a detailed history of how many pads she's using, how many days is she bleeding, and what is the difference between for the past 6 months and before that. Is it worsening, or is it something which has been, the routine thing? And ultrasound, I'm very happy with the ultrasound, but I would do the basic other blood workup and look at the whole picture. If there is anemia, I will correct that first. But if she's persistent and she's very scared of the myomas, if they're very particular, I would probably suggest an MRI with significant, saying that it is not going to make any difference in the treatment. It is just for them. Because a lot of times what happens is, if you don't suggest it, they go back read Google and get suggestions from them and do unnecessary tests and come back. It's better you talk with the patient and ask what their real scare, why are they worried about, and then discuss it in detail with them.
Yeah. So any other test my panelists want to add? She said we're going to do a hemogram and everything for the blood test with her. We'll do a TSH for her. Anything else? She has got this little heavy menstrual bleeding. She has got a dysmenorrhea. Anything else you would like to test or do in your blood test? Any of the panelists? It's just open to all for a good discussion. Archana,
I prefer CA 125.
125, yeah.
CA 125. Okay, CA 125.
In endometriosis, there will be my minimal rise.
Yeah. So anything else?
And to give her like it's not a CA, to prove that it's not a CA.
Anything else?
Ma'am, I would just like to do a meticulous 2D ultrasound and if possible supplement it with a 3D. So my main concern is to rule out any adenomyosis which might be there. So because the dysmenorrhea she is having is not because of these fibroids, they are almost insignificant. The size is around
So
one.
would like to redo.
Yeah. Maybe do it now or maybe keep her in follow-up. Explain her she might be having either subtle endometriosis or adenomyosis.
Associated pathologies which may be really responsible for this dysmenorrhea, maybe some adenomyosis small, or maybe some leaks which could be there which are not seen by the previous sonogram. Anything else you want to rule out? Dr. Omar?
There is an enlarged echogenic ovary, so would like to rule out endometriotic cyst as well.
Yes, so done for endometriotic. Anything else? Now, we can move on, and I think we also need to rule out any history of a pelvic inflammatory disease or maybe a UTI. She has a pain. So we'll do investigations even for them and a history of trauma or inherited. Of course, you've done your acquired bleeding diathesis. So we needed to project that AUB is not always due to the ultrasound reports like the small fibroids, which Mansi also said that we always keep having these reports and a patient comes to us and says, yes, I have these problems and I've got this fibroid. What I do it. So this is the basic messages that we want to send. And now we have that do you opt, of course, now we've done this. So we want to give a relief of signs and symptoms. We want a little reduction in the size of the fibroid. We want to maintain her fertility and we don't want to do her any harm. So Dr. Archana, now, do you want to fiddle with this fibroid? Because she's poking you, I have this fibroid. Or you want to go in for a medical option for this patient?
This patient, her fibroids are very small. I don't think I really want to go ahead with anything medical or surgical. Maybe I'll just tell her we can follow it up.
So you want to just keep a follow-up, not even go for
That's what I'll advise and try to convince her.
Else, but I need to cure her of her bleeding. I need to cure her of her pain. So out of all these, what would you choose as your medical option, Dr. Archana?
In this patient, for her pain, I think my first choice would be tranexamic acid and NSAIDs.
So first NSAIDs or first tranexamic acid?
Ma'am?
You want to put her on NSAIDs first or tranexamic acid? You want to put her on
tranexamic acid.
Wants to add NSAIDs.
That would be my first choice. So now we have combinations, so I think we can go for that.
Any difference of opinion by my panelists?
NSAIDs will be a first line of drug, ma'am, because that will reduce the bleeding also.
So you want to go in for tranexamic and NSAIDs?
NSAIDs first.
Okay. Any difference of opinion?
A combination of both.
The other options. Nobody wants to go in for COCs. Nobody wants to go in for progesterone. Okay. So we decide by the panel that the first line of action would be an NSAID and tranexamic acid. You put her for this medication, but she did not respond. What do I do? Open to all my panelists.
I'll go for combined oral contraceptive pills.
So Dr. Umar said, we're going to move on contraceptives. Do all my panelists agree? Yes, I think I can go by silence as yes. We all agree that you can put her on contraceptive pills. Now, Dr. Umar put her on the contraceptive pills and she came back after 3 months and she said, ma'am, look at this report. The fibroid reports again is 14 by 12 and 10 by 12 millimeters. So what was a wrong thing that went over here before the patient left your chamber? Anything that we missed out?
counseling.
Fantastic.
Talking to her.
That's a counseling that we need to tell her before putting her that is going to reduce your menstrual bleeding, but it's not going to touch upon your fibroid. As you had this as your priority complaint, so we are going to deal with this and rather than putting up anything else. Now, Dr. Jayachitra, do you anytime have put your patients on LNG in adolescent girls? Did you have they may be sexually active? So yes, you can go in. So Jayachitra, did you have an opportunity and what's your experience with LNG in adolescent?
No, ma'am, I haven't done that. But for one patient with severe menorrhagia, she didn't have any other problem except for polycystic ovaries. I tried contraceptive pills, everything. But still she was having hyperplasia. So I had to go and do a endometrial biopsy with undershot GA. That is the only thing I've done for her. She was a 14-year-old girl. We ruled out everything, all bleeding disorders, everything we ruled out. So we had to go for, that is the only thing I've done. But literature says that LNG in adolescents, there are so many studies saying that adolescent girls who are sexually active or even for girls who have severe heavy menstrual bleeding and severe dysmenorrhea, LNG is one option.
Yeah. So thank you so much. And now we move to Dr. Mansi. Anytime she has an enlarged uterus, she's got a lot of dysmenorrhea in an adolescent, you will prefer any time to give her a GnRH analog?
Ma'am, GnRH analogs are to be avoided in adolescents and not to be given. Reason being the epiphyseal growth, the bone closure takes place around 17 to 18 years, and GnRH analogs, they cause bone mineral loss density. So, it should be avoided.
Fantastic. So I think one is LNG in adolescents, sexually active could be used, but the problem is that acceptance to IUCDs in Indian population is a little less in the adolescent population. Yes, and of course, once he said that bone mineral density, there'll be a serious issue of that. So she'll start having the menopausal symptoms as well as the cost and the add-back therapy needs to be given. So that's a reason we usually avoid. Now, we put her on contraceptives. Anybody wants to add anything?
Ma'am, I had two patients who are not adolescent, but they're 19 and 20 years old. They both had a polyp. Hysteroscopic polypectomy was done. Hemoglobin is severely anemic. Both of them we had inserted LNG and removed it after 3 years. Actually, they're doing fantastic, and one of them has already gotten married, and she's pregnant now. So that definitely is an option, even though they were not sexually active. But they had a polyp. So it was an endometrial polyp, huge, 3 into 2 centimeter. So hysteroscopic removal within LNG was done for 2 of them, unmarried girls.
Right. So that's how we got that experience that yes, this could be options. So this must be open into our mind. And now we put her on COCs, but still she didn't respond. Dr. Oma, what do we do now? Any other option? Dr. Oma?
Yes, madam.
Dr. Uma, are you there?
Yes, madam.
Yeah.
Yes. She's on OCPs but not responding to OCPs, right?
Not responding to OCPs also. We are not interested in putting her LNG. We are not interested because once he said yes, VMD is an issue, we are not going to give a GnRH analog. Any other option we have for her treatment?
Ultrasound guided radio frequency ablation, ma'am.
Any other option?
Register only.
Progesterone, madam.
Registrants.
Any other option? Right. So we could also go in for the SPRMs over here, and we could put her on SPRMs because it's been seen that at low doses, mifepristone blocks progesterone by competitively binding to its intracellular receptor. So that could have been a good option for them. Dr. Nivedita, any role of a watchful expectancy? I don't do anything for this patient?
No, ma'am. I'll do.
No. So we completely agree, all of us, that we should have given her something, and we've given her NSAIDs with tranexamic, and then we tried some COCs, then we went to a mifepristone, and leaving aside by choice if she wants to go for some LNG, and that also if it is required. She was not responding, she had a bulky uterus, and so on. So there could be some points. Now she is asymptomatic or mild symptoms. We need to really assure them. Now, could you tell me any situations where when she's asymptomatic, yet we need to remove this fibroid. It's open to all my panelists. She is asymptomatic, but yet I will go on and decide that I will remove this fibroid.
Size of the fibroid is more than 4 or 5 centimeter.
Yes, it's a size. It's something 12, 14 weeks of a pregnancy.
Large fibroids.
So what is large fibroid? Anything else?
Pedunculated
Sudden change in the
fibroids, which
size
might
and
undergo torsion.
Yes, it's a subserous
degenerative
pedunculated
changes.
fibroid, so it can undergo torsion. Any other indication?
And sudden increase in size, pain, the sudden onset of pain, and degenerative changes in the fibroid. When the fibroid
Growing fibroid, I need to take a decision. Anything else? I put my ultrasound.
And general submucous.
There is a evidence of any hydroureter, any hydronephrosis, and its compression of the uterus by the tumor. I need to take a decision. So let's keep moving forward. Now, this is a 25-year-old woman, and it comes to an OPD with regular cycle. She's married for 1 year, and she says, I desire early conception. She's got an interstitial myoma, which is 30 to 35 millimeters, ovaries normal, antral follicle good count. She's got a triple layer of endometrium. And now she says that she's no conception, whether I'll get a pregnancy, there's a risk of malignancy, so many things coming into her mind. And now what do we do for this patient? Her husband is in the army, is in the Navy, and is gone out for 6 months. So now she has to decide. Dr. Swati, we need to decide for her now which fibroids I need to take care. They are of concern and they're going to disturb me all the time.
Any fibroid which abuts the endometrial cavity or distorts the uterine cavity.
Yes.
No matter what size it is, as Kuldeep Jain sir said, any fibroid which distorts the endometrial cavity.
Small 1 centimeter is going to scoop off. Beautifully showed us you got the endometrium and you got it feel. Yes. Any other
type
one?
0, 1 and 2.
Yes.
And 3 if it touches the endometrium.
If it touches, yes. Any other? You're not going
Intramural fibroids more than 5 centimeter in size.
Intramural, you're going to remove?
More than 5 centimeter, large intramural fibroid.
Any other fibroids? Yes, you need to remove them.
It's in the palm.
Okay.
The fibroids are distorting the tubes. If there is causing any tubal pathology.
It's in the cornal portion of the uterus. It's excluding you. There's so many multiple myomas. Dr. Advan said you go on mapping. Yes, I'm mapping, but there's still much more than that. They're blocking my tube.
Oops.
So I need to do something for them. And so any other things? Cervical myoma. It may so I need to take decision and go on evaluating. Now we come back to a case, and she's got 30, 35 millimeter intramural. Husband is out in the Navy, 6 months of time. Now, what do I do, Dr. Gayatri? How are you going to plan? Do you wish to treat? Do you want to do a surgery? Fast forward, sir says, fantastic surgery, good results. You're going to do, but you know what happens? Surgeon, what decision are you going to do? You're going to do a medical.
No, I'm not going to do a medical at present. I need to know what all the other evaluations have been done. So how long has she actually been with the husband? So you said he's in the Navy and they're married 2 years.
Husband studies all normal.
Okay. And how long have they lived with each other? If it's less than 6 months or 8 months, I would give them a time at least for a year if they have lived with each other. Then probably decide according to the mapping of their fibroids and then decide what my interventions are. If I give them an option, I would probably suggest surgery as the first option. And if discuss the pros and cons, counsel them very well. Or if they take a call saying that they would like to wait for 2-3 months and then reassess the situation, I would actually wait for 2-3 months and then reassess the situation.
Okay. So her husband is out for 6 months. Anything you can do for her?
Probably try a medical management for 3 months, reassess it and then decide.
So, sometimes what happens, surgeon feels that myomectomy is going to enhance fertility in all patients. On the contrary, it may not be very useful. Sometimes end up into so many tubal adhesions or the way relationships or something may happen. So it's a very, very crucial decision. We had time. So Gayatri decided that, yes, I will put her onto medical management. Now, Dr. Archana, right? We have a whole list of medical options. So we're going to go for medical now. What are you going to put her on? OCPs, you're going to put her on progestins, you're going to put her on. What are you going to choose out of this list?
The OCPs and progesterones really don't reduce the size, what we are looking at for this patient when we're considering fertility. So probably I'll go ahead with either the SPR
Yeah, you want to go for
or the GnRH analogs if I want to try a medical management
tell
for.
you choose. So you're not going to go for progestins. You're not going to, because you say, yes, they may have all these side effects. Injectable MPA, no. COCs, you said no. Okay. Now, if I ask you, out of the two GnRH and your SPRMs, what would be your preference of choice?
If I'm still planning for a surgery, after a trial of medical management, I'd prefer to go for GnRH analogs, madam.
Yeah. Any difference of opinion? Anybody wants to go for anything else?
Ma'am, actually,
And
when
if you
she
were to go
came
for a
in the
difference of
first
opinion,
case,
why?
yeah. So, ma'am, in the first case, she was anxious to conceive. So, I think it's more important to find the cause of her infertility. I would
Found out all the
investigate
other causes. Everything is going well. We've given them
everything
a
is
try.
going well. So, I'm not going to touch this fibroid because this fibroid per se is not the cause of
Decided
infertility.
you're
You
not
said
going to
it's
touch
not.
the fibroid.
Yeah,
Now,
it's
give her
not.
treatment.
Yeah, so like if she's already, you said the husband is living far, so I'll give them the option of doing an IUI, freeze the semen and go for an IUI, have a decent, if the tubal status is normal, so have a decent 3 or 4 cycles. She seems to be young. I think I missed out the age. I'll give her a fair trial of IUI first and
Okay.
not touch the
But you know
fibroid
that
straight
she
away.
decided that we are going to, as I said, we are going to give a medical management. Now, I want you to choose the medical management, GnRH analog, or you're going to SPRM. And why are you going to choose? So any of my panelists can give an opinion. It's a free open discussion that we're going to go on so that we have a lot of inputs. Now, anybody wants to choose SPRM first?
I would go for SPRM, ma'am, but for this particular size of fibroid,
yeah,
I would not opt for a GnRH.
Okay. Now, we'll come to it later that why Swati said, I am going to opt for an SPRM. Okay. Now, the myoma growth, the past was that it's being fueled by estrogen. But the present says that there are progesterone receptors, which are required for the cellular proliferation of the fibroid growth. And they are elevated. They're both types of receptors, progesterone A and B. So progesterone receptors, they are the potential targets now for inhibiting the fibroid growth over here. So why we said, because progesterone receptors are 3 times higher in fibroid as in myometrial and estrogen receptor expression on the uterine cells. So what do they do? Progesterone is believed to have a dual action. It's going to have a progressive as well as an inhibitory action. Now it increases the BCL2 protein expression. So it's going to inhibit apoptosis, increasing EGF expression, angiogenesis, but on the other hand, it's going to decrease the TNF alpha expression and therefore decrease fibroid cell proliferation. And so we picked it up that yes, we are going to use the SPRMs over here. Now, my second question is, why, Swati, you picked up this in comparison to the GnRH analog? Why you found some advantage? That's why you said, I'll pick up SPRM.
Because of the size, ma'am, because GnRH analogs work better with a larger size of fibroid. When it is like 3 to 4 centimeters, I would definitely go with the SPRM.
Yeah, but I think something more came into Swati's mind and she picked it. Why? Because she found that the SPRMs have got a direct action, and they're going to inhibit the proliferation of the fibroid and induce apoptosis. If you look into the endometrium, it's going to have a direct effect. It's going to stop the uterine bleeding. And yes, on the pituitary also we know direct. But what happens with GnRH? The direct action inducing down regulation, there's going to be desensitization of the GnRH receptor, and it's going to create a hypogonadotrophic state. And so she's a young patient. So that's why I think, Swati, you had something in mind and you selected your SPRMs. And yes, we have so many clinical trials. We have got control trials for them, and we have different doses of using this SPRM with us. Now, Jayachitra, your experience with mifepristone. We know it can be used with 10 and 25 milligrams. So what is your choice of using? You want to use a 10? You want to use a 25 milligram?
Usually I go for 25 milligram, ma'am. We start with 25 milligram and give it for 3 months and reassess the patient 3 months later.
Now, if the size has not decreased, what do you do? Do you move on to a higher dose? Do you stop? Do you change your medication? Any of the panelists can go on with their experience. Anybody uses 50 at the start? Anybody uses 25 and 50, 25 and 50 depending on the size? Any difference of opinion?
No, ma'am, I usually start with the low dose 10 milligram and then step up to 25. That's usually what I do.
Yes. So there could be different regime that anybody is using. Sometimes this woman is symptomatic. You may just give a short-term use of your SPRM. You may give a 50 milligram and thereby see the size. She's responding well. You're continuing with this 50 milligram. And also, she's having a lot of uterine vaginal bleeding. So you started with a 50 milligram of the dose, or you could begin with 25, as Dr. Jayatita said. She started responding very well. She started reducing the dose. Every 3 months, you could reduce the dose for us. But sometimes you must have found that we have patients who just, say, I keep having spotting, I keep having bleeding. So what happens when you were using your 25 milligram, and you're using a 10 milligram or maybe a lower dose, they start having infrequent bleeding. And after you use a little higher dose, they have a complete amenorrhea. So it is better for them to be used as a higher dose. Now, if you're going to the reduction and you compare a slighter dose with much, you find that after 3 months, reduction is much more with a higher dose.
170 rupees on Google Pay for Business.
So you can start with the higher dose also and see her response, and thereby you can taper the dose. If it's a small size deep intramural, you can give her for 50 milligrams. She responds fantastically well. Now, I just wanted to ask you, when you're putting them on mifepristone, right? So do you monitor something else with ultrasound apart from the fibroid?
Liver function test, ma'am.
Okay, done with liver function. Anything else when you're putting ultrasound, you need to keep an eye?
Endometrial hyperplasia.
Fantastic. That's endometrial hyperplasia. Now, Dr. Archana, you found that she's got endometrial hyperplasia. What do we do? She says, you put me on drug, doctor, but I've got this endometrial hyperplasia. Tomorrow I'll have endometrial. See, what is this? So what are you going to do? Any of the panelists can
discontinue.
You're going to discontinue the drug, but I'm not going to. Anybody else wants to discontinue the drug? What happens is when you're monitoring these patients, it's been found with different studies which has gone that these endometrial biopsies which were done for this patient never showed any pre-malignant changes, and all these hyperplasias were atypical. So I can just counsel her, continue with my drug, and the beautiful was of this drug was that as compared to the GnRH analogs, there was no risk of BMD, there was no osteoporosis, and very little elevation or no of the enzymes over there. So we started using this drug. And I just want to ask you one more thing. When you're going to, this patient is asked to go into that, I'm stopped with my periods. When is it that I'm going to resume my periods? So my panelists, tell me, when is my patient going to resume her periods after I stop this therapy?
Within a month, ma'am. Maximum by a month, she will resume her periods.
Yes. So it's a time period of around 34 days, but it can last somewhere between 5 to 85 days. So if you counsel her, yes, you need so much of time. And we started from day 1 to 7 of the period and take it at the same time. And when do you call these patients? So follow up. The first scan, you've started mifepristone. After how many months? 1 month, 2 months, 3 months, straight away at 6 months.
3 months.
Yes. So a time period of 3 to 6 months. Never call her before that because you're not going to respond before this. Dr. Mansi, are you using ulipristal in your practice?
Ma'am, Ulipristal, I believe, has been banned in India for, I think, last 2 years because of the side effects on liver. But personally, because I'm dealing only with infertility population, and there is a very limited role of medical management in infertility patients, so I have no experience with Ulipristal.
I've used, ma'am, but not in infertility patient with the in perimenopausal women, and it gives a very good results actually. Not, but not perimenopausal, 30, 35, that age group patients, for a period of 3 months.
But it's back again with us.
Yeah,
And
it is back.
yes, we need to do monitoring of our liver function test
LFT.
first and in between. And believe it, when this drug was there, it used to do fantastic results, into decreasing the size. So it was a wonder drug. Some have come back using with it, and some are still onto it, not using with it. So I'll be cutting short a little because of the constraint of times. And sometimes, we have some intramural fibroids, not distorting cavity. But is it any time, Mansi, we need to remove this intramural? They're not distorting a cavity. But is it sometime you need to decide, I'll remove this intramural fibroid? So what is that decision?
Causing
Ma'am,
compression.
sorry, I didn't get the question. I didn't hear you.
Mansi? Hello? I think some network issue. So any size that you decide, yes, we need to remove it. Even if it is asymptomatic, it is not distorting the cavity.
More than 5 centimeters.
Yes, I think sometime we have to take a decision that yes, we need to remove all these fibroids because they really interfere with your vascular flow and say. So we come back to the next decision. Now this woman got pregnant with that fibroid, and now she's 3 months pregnant and gets back to her maternal place. And the obstetrician is worried. Yes, she's got a pregnancy now. And what do I do? Now there are a lot of queries you have to answer. This patient has a lot of queries. Dr. Uma, will I get an abortion? Am I going to have a miscarriage with this pregnancy? With this fibroid?
Yes, there is a chance for miscarriage. Actually, spontaneous miscarriage rates are greatly increased. It's about 14% in pregnant women with fibroids.
We've already seen that this is not near the endometrium. It's far away from the endometrium. So does she carry increased chances of a miscarriage?
Actually, multiple fibroids and those fibroids located in the upper segment and submucous fibroids are more prone for
miscarriage. So this patient had little chance of a miscarriage. Dr. Nivedita, now she said, ma'am, will this tumor, I got a pregnancy, I'm worried, will this go on increasing in size? Nivedita?
Sorry. Yeah, ma'am. Sorry. Obviously, in first trimester, that we can say increase in size because of the estrogen level and hormones produced from maternal, fetal, and placental factors. But after second or third trimester, there won't be much increase. So the patient is obviously coming after 3 months. So I don't panic the patient with the saying it will increase.
Yes, we are there to take care of you. No worries, it's not necessary. Now, Dr. Swati, she said, madam, at any time, will I require surgery? I'm going to carry on this pregnancy. How are you going to tell her yes or no? Are you going to convince her? Is there any
Now that she's crossed the first 3 months of her pregnancy, the chances of it growing more bigger is definitely comparatively less because fibroids grow more bigger in the first trimester and compared to the second and third trimester. But if at all there is a need for surgery, it would be if she has any red degeneration with pain or because of the location of fibroid, which might hinder her delivery.
Now let's take what you said as red degeneration. To my panelists, now what do you do if she gets a red degeneration?
First, we would treat her with NACI.
Medical management first.
Medical management.
So what the concept was earlier was that, yes, we were red degeneration, we used to opt out, but now it's just even we have to counsel her at any point of time because you don't have a pedunculated subserous or anything which is all distorting. So even for red degeneration, which is known but yet a very rare complication, you need to go in for a conservative management. Now, Dr. Gayatri, is she a high-risk pregnancy? is she a high risk pregnancy? Because we have to put the red marks, yes, you're high risk and you need to be marked. Is she a high risk pregnancy?
Yes.
For a 3
Yes,
centimeter fibroid, if she has crossed 3 months, I don't really put a red signal there.
Yeah.
But she is somebody who need a close watch.
So
she's
no
not
harm
somebody.
counseling her that yes, you could have any time preterm, placenta deliberation or malpresentation or anything. Yes, we put a red blood to her. Now, there was an IUGR, fluid decreased very fast. She had an oligohydramnios. So you planned her for a cesarean section. Open to all my panelists. Now she says, doctor, if you're going to do a cesarean, please do a myomectomy. How many of you are going to opt out for the myomectomy along with the cesarean section? To my panelists, don't mind if I'm going a little fast. Archana, are you going to do a myomectomy? Yes or no?
Not as a routine, madam, but if it is there in the lower segment, lower uterine segment,
If in the
or
lower
it's a very
segment,
large one and
are you
all
going
that,
to do it?
we
Not as a
can do
routine,
it.
ma'am.
If it's required, we can go.
The patient says you do it.
Ahead with
Are
it.
you going to opt for it? You said if it were only in the left segment, I'll do it, otherwise not. Mansi, endoscopy, fantastic. Are you going to do with the cesarean myomectomy on a request? Mansi, are you there? Dr. Uma?
Yeah, I'm sorry, I'm here.
Yeah.
I just forgot to unmute
Mansi?
myself. So I wouldn't go for a planned
Mansi
myomectomy
is not
during
going to do. She
cesarean.
says
It's
you
going to
come
be
back to
very
me, I'll do a
vascular.
laparoscopy for you later on. Are you going to do this? Are you going to follow the patient's request or not? Dr. Uma, please keep yourself
No, ma'am.
unmuted so that we can.
No, ma'am.
No. Nivedita, are you
No,
going to
ma'am.
opt?
I won't give any assurance, ma'am.
No assurance.
Intraoperatively, I'll
Bharti, what
decide.
is your opinion?
I mean, intraoperatively, I'll assess and then I'll take a decision, ma'am.
Swati is going to decide intraoperative, but it's very difficult. Swati, you'll have to plan beforehand. Why?
Consent.
Because, you need a good expertise for doing a cesarean myomectomy. She may do very well or she may not do very well. You may have a torrential bleed and you may need your bloods and everything. So I think we shouldn't go by the patient. We should decide for a cesarean myomectomy according to the expertise, experience, and also that you have all the things ready with you. Now, decision making, we need alternatives, uncertainty, so many high consequences and interpersonal issues, complexity, but yet my panelists are going to go fast with me. Now, this is a 26-year primary infertility, 4 years, menstrual history, okay, BMI is 22, hormonal profile, absolutely okay, HSG, bilateral spill, proliferative endometrium. She has a submucous fibroid, which is 3 centimeter, and husband's parameters are all normal. Now, the treatment plan, it was planned, we're going to do a controlled ovarian stimulation with an IUI. Now we found that she has so Dr. Archana, she was put on a controlled ovarian stimulation. She was sent to you because the center didn't have that monitoring, and you found that this is a submucous fibroid. Dr. Archana, what are you going to do next? Are you going to carry on with the cycle?
I would not proceed with the IUI, madam. As a submucous fibroid, I consider for a
this cycle. Anybody else who wants to continue with the cycle?
not for a 3 centimeter submucous fibroid, madam.
No.
No, Gayatri doesn't agree. Now, Mansi, what are you going to do?
Ma'am, she has to, that fibroid needs to go. It has to be removed.
You very sure?
Very sure. Submucous, there is no doubt.
No doubt. Nivedita?
Yes, ma'am. Obviously, we have to remove the
So
fibroid.
it's a 50-50 issue. So let's go into the evidences, So what evidence says is that look at the pregnancy rate. When it's a subserous, it's 27% and intramural 16%. But look at submucous. It's just 9%. That means the submucous has got the most detrimental effect. And if you go into this clinical pregnancy rates, 14%. And look at the abortion, spontaneous miscarriages. It's 47%. So with these data, as you say, if you remove this fibroid, and not only this, look what it's going to do. There is a reduction in the levels of endometrial HOXA 10 and 11 expression, both over the myoma. This submucous is going to cause endometrial erosion, very hostile environment, disrupting the endometrial blood supply. Not only this, the junctional zone is very important. It's a functional important entity. All the changes of implantation are going to take care. So this is going to be disturbed. And also, there's going to be an increased intracellular calcium, so a lot of contractility. If there is so much concern, why don't we go in for a surgery before removing it and going for an IUI? Dr. Chatra, we'll go very fast. We've done a lot of ultrasound. What are you going to use your parameters for diagnosing and confirming it and going before your surgery?
We have to do a proper 2D ultrasound, ma'am, to know the location of the myoma.
What else apart from the fibroid are you going to look into the transvaginal? We would want, you want to decide, you may like to do it histoscopically. What are you going to see in this transvaginal ultrasound? Anybody? Nivedita, Swati?
Size, location, number,
Morphological
exact
features.
mapping of the fibroids, exactly where is the location, the distance from the endometrial cavity.
Kuldeep Jens are stressed, you know. You're going to buffer it if you're not careful. I'm going to see the, free myometrial margin. He said, you must have around 1 centimeters. So I'm going to look into it. Dr. Ladman said, I'm going to map it. You're going to do your mapping. You're going to do your SIS. Is it
And
not?
ma'am, this is where 3D really helps. 3D has definitely revolutionized it. Also eliminates the use or the need for MRI in most of the cases.
Yes. So you're going to individualize everything. And Mansi, you're there. You've got a lot of residents with you, and you want to give the surgery to your resident. Go ahead, do it. What is it which makes you decide whether my resident can do it or I need to do? We've already covered all this, but just for my, delegates who have joined here, something which I need to see before I move that my resident can do it. I give a go. What is that? You're classifying, you're mapping. Which mapping, which classification we've gone
Sir, I think has already covered all this beautifully. The step W classification, if you're going for a hysteroscopy approach, so it helps you in...
which we'll go into, so I'm moving fast. We've done this, and we say it's 0 to 4. It's a low complexity. My resident can do it. My junior doctor can do it. But I need to be there if she's 5 to 6, and I need to be there or hand over to somebody who's expertise for hysteroscopic myomectomy. It says 7 to 9. So, Dr. Uma, what are you looking into? The complications, you might have everything in your mind. 1, 2, 3, 4. Dr. Uma, complications of hysteroscopic myomectomy. I need to stop. I need to see this.
Gas symbolism.
Pardon, Dr. Uma? Dr. Uma, are you there? Okay, anybody can take it up.
Ma'am, fluid overload, it's a big fibroid. It's going to take time. So one person has to be in the OT just monitoring the fluid intake at any point of time. If you cross 1000 ml, you need to stop. Above 1200, definitely you need to shut down the procedure. And fluid overload is one thing. Then it's a big fibroid. There are times when, you have to already counsel the patient for a two-step myomectomy because this is a big fibroid. So these things have to be explained to the patient.
And perforation occurs.
Perforation, yes, if you're using a resectoscope. So yeah.
Bleeding.
Any injury, any
bleeding,
perforation, anything. Now we move on. Dr. Nivedita, the surgery has been done well. Okay. Now post-operative advice. What post-operative advice are you going to put?
Mainly post-operative endometritis. For that, we have to give proper antibiotic, and adhesions may occur. So for that, we have to suggest for IUCD or hormonal IUD.
Now, what is your choice? You want to put it in IUCD? How do you decide? You want to give a estrogen
I prefer hormonal IUD.
Hormonal IUDs? IUCD? Anybody else in the panel wants to agree or disagree? You put IUCDs? Need clean surgery?
No
IUCD. No IUCD. If it's a surgery, I do not think we need to do anything. We don't need to put them on IUCDs. Like we have a beautiful, we've done everything, nothing, no disturbances. And if you find it's a difficult surgery, what would you like to use? You would like to put a Foley's catheter?
Yeah, ma'am.
Any of you? Nivedita wants to put a Foley's catheter, then after how much time do you
hyaluronic gel.
Yeah, pardon?
Hyaluronic gel.
Yeah. But how many of us do put a Foley's catheter? Yes, we don't usually put, we give an estrogen progesterone combination. And that's what we prefer. And we give it for how much time do we give an estrogen progesterone combinations?
3 cycles.
Yeah, you give it around 4 to 8 weeks, and that's a proper time. Now, you've done a surgery, you've decided for post-operative. Now you want to advise her. After how much time of a myomectomy she should take a pregnancy?
After 6 to
3
8
months.
weeks, we have to redo hysteroscopy. The
1 month, 2 months, 3 months, 6 months, how many?
3 months.
3 months.
Minimum 3 months.
Yes, minimum 3 months.
Are you very sure?
I prefer 2 months.
So one person is going for 2 months. Anybody else wants to differ? I'll tell her after 6 months. Go and have a holiday and then come back, and then we'll have try for the pregnancy. So let's look into the data, what it says. When they monitored and they did the MRI images and they analyzed these patients, they found that if you look into the endometrium, it's approximately on the myometrium, it takes around 6 weeks for the myometrium after you've done a myometry to come back. But when they started looking at the endometrium, they said it takes almost a 12 weeks time to have a proper recovery. And so that's the reason that we tell our patients to come back after 3 months and take a proper, plan for their pregnancy. And we move to the last quick decision. This patient is around 30 years of age, infertility 6 years. Swati, this is going to go for you. Menstrual history normal, BMI normal, hormone profile normal, spill normal, HSG, everything is okay. And the doctor started stimulating her with letrozole, 2.5 milligram for 5 days. Suddenly, when they were on the 9th day of stimulation, this hyperechoic area was seen. She was planned for IUI. Now, should she go in for this IUI or should we cancel this IUI? Are you going to take something to decide what I need to do?
Hyperechoic area covering seen in the endometrial cavity can either be a submucous fibroid, which could have been missed out in ultrasound.
Okay.
Polyp also can be kept in mind, endometrial polyp.
Endometrial polyp? Yes. So what are you going to do? You need to confirm now. It's a polyp. It's a submucous. What do you do?
Would go ahead with the TVS.
We've done the TVS. Next.
MRI.
No, at this time,
Or
to MRI. So we keep her with us. She's going to run away from subject now. Something
3D ultrasound.
Just on your buttons.
Hysteroscopy.
Proceed with the IUI probably.
Before proceeding, we're going to make a decision, right now. Swati, you're sitting with your machine.
Saline ultrasonography.
3D ultrasound.
Or 3D ultrasonography.
3D ultrasound.
3D ultrasonography. Anything else? I want you to tell me.
Vascularity, the Doppler. Vascularity.
It's wonderful. Just put in your color Doppler and you see a feeding vessel, you can decide it's a polyp or it's a submucous fibroid. You can do your SIS, but if you do your SIS, then are you going to go for an IUI? Are you going to go for IUI in the same cycle? No. So you're going to cancel the IUI if you're going to do an SIS. And if you've done your color Doppler, and you find that there is a polyp, then what are you going to do? You're going to cancel?
Just ask her to go for a timed intercourse, ma'am. And if it becomes negative, then we can go for a...
IUI is cancelled, I think,
Yeah, cancelled.
It was a polyp. You took this decision because if you look into the data and if you look into the evidence, it says hysteroscopic removal polyps prior to IUI increases the odds of clinical pregnancy. And the different studies said it even improves the implantation rate. So we decide we're going to cancel, we're going to do the polypectomy, but do not forget to follow up any of your fibroid patients. And because the recurrence of fibroids following myomectomy is there, series of 622 patients, 27% recurrence, women who give birth are less likely to have this recurrence. So keep following your patients and be with them. And yes, it was a passion. We went very fast, but we were able to manage so many of our cases over here. So a safe landing for all of us. And thank you to all my panelists. And please excuse me if I went a little fast because of this time we were crossing, but we wanted to give all beautiful and wonderful messages to all our delegates who are there. So
thank you, madam.
So much.
Thank you, ma'am.
Thank you so much for giving us very quick and useful inputs. And I think it's going to go a long way with our practice of clinical. Thank you. Thank you to Jai Chitra, Archana, Mansi, Oma, Dr. Nivedita, Dr. Swati, and Dr. Gayatri. Thank you, ma'am.
Thank you, ma'am.
Thank you so much, ma'am, for the insightful and the thought-provoking panel discussion and finishing it off, even though a little bit fast, but on time. And we gained a lot of knowledge from it, compiling everything what we learned from the beginning about ultrasound and laparoscopy, and then in between all the clinical things. Wonderful inputs by all the panelists. Thank you so much for the wonderful discussion. So we convene a session here. It
Thank you
was
to all, SIG ultrasound group, our mentor, Dr. Shokurana, Dr. Bharti Madam is always, she's always taking us forward. She's always there with us anytime. So thank you, Bharti Madam, for always inspiring us, for being with us. And Dr. Ladbans Madam and myself from the ultrasound SIG group with Dr. Kuldeep Jan, we saw a stalwart, a real stalwart, and wonderful, operating skills. And he's given us so beautiful tips. Thank you, sir. Dr. Padal Kodawala, we were missing, we couldn't join. And Dr. Mansi is there as the co-convener. Thank you, Mansi. And Dr. Chitra, whose hard efforts, put us connecting with our IFS South Tamil Nadu chapter. Thank you, Chitra Madam, for all the initiative and for giving us and being with us till the end. Dr. Chandra Madam is there with us.
Thank you.
Thank you all the panelists. And thank you, Priyanka. Wonderful job. And I think a flawless execution. Thank you and Conference International for the platform. Thank you so much. And I think we wish goodbye till we all meet again. Thank you. Thank you. Bye.
Thank you, madam.
Bye. Thank you.